So the interrelated concepts are fluid and electrolyte imbalances and acid-base balance. We are not going to go dive deep into all this. So I have introduced fluid electrolyte imbalances, ABG imbalances. So we're going to just kind of build on it. Okay. This is a very straightforward chapter, guys.
Yeah.
So this is your basic anatomy: kidneys, ureters, bladder, urethra, and the exit. Structure of kidneys, we're not going to go into details. Again, it's like not A&P class, so read your textbook, get familiar. I mean, like, just get familiar. Like, you know, just get familiar. Like, I'm not going to test you guys just for your med-surg 2. Okay, just for your med-surg 2, because, you know, it will go into like good depth. Anatomy of your nephron, your renal tubules, so your bladder. Okay, so what kind of muscle is that? You just came back from break.
Sorry.
You've done it now before.
I wasn't on a break. I was remediating because I felt it.
Yeah, that's why, I don't know, what if my professor told us one time, please bring your leg bags. We can only give so many grades.
Yeah.
Okay. Let's jump into age-related changes. Okay, just for the basic A&P, skim over that section, get familiar with a few of the terms. So, as we know, like as we age, our body is changing constantly, declining. So, cortical tissue loss. Okay, what does that mean? It means your nephrons are getting smaller with age, so it means the blood flow to the kidney is decreasing. Okay, so your kidneys are not getting as adequate perfusion. Then we have, again, cortical tissues loss, smaller nephrons, same thing, back to back. Then we have decreased GFR. What is GFR? Filtration rate. So for this one, it's going to decrease. We are going to monitor for hydration status and use caution when you're giving any medications, especially if they're nephrotoxic medications. Okay, so give me an example of some of the nephrotoxic medications.
Vancomycin.
Vancomycin, gentamicin, contrast. I mean, if there's a procedure that involves contrast. Then we have our nocturia, that's urination, increased urination at night. Okay, so with the age, we are going to go back into that home assessment. Okay, we want to make sure, you know, that they have adequate lighting at night, so they're not walking in dark, tripping and falling. Okay, there's like no hazards getting up from bed and going to the bathroom, because we're trying to prevent what? Falls and injuries. Okay, and if possible, then we can have a bedside commode, a urinal, or a bedpan at bedside. Okay? And again, with elderly adults, we try not to give them so much fluids, like 2 to 4 hours before bedtime. Okay? If there are any diuretics, for example, like Lasix, if your patient is taking Lasix, we try to schedule that Lasix in the morning so they're done diuresing before the bedtime. Okay? The latest, like in my practice, the latest I would go is like maybe 4 o'clock. If their bedtime is at like 8 or 9, 4 o'clock I can give Lasix, so they have like good 4 or 5 hours to diurese. So just we can avoid that nighttime waking up, nighttime urination, and then avoid any injuries or, you know, any safety events. Then age, what happened, there's a change in our detrusor muscle. So we know our muscle, like, you know, our bladder is a detrusor muscle. So there is a decrease in the elasticity of this detrusor muscle. and the ability to retain urine is decreased. Okay? And when the decreased bladder capacity is decreased, okay, your patient is going to have incontinence. Okay, because your bladder is not able to hold on to the urine. So we are losing that nursing bladder. You can't go 8 hours without peeing. So we are looking for what? Okay, we are having like those toileting schedules, like we are going to offer bathroom breaks like every 2 hours. So going back to reflecting back to our last week's lecture when we're doing our rounds, like, you know, those 4 or 5 P's we assess. Potty pee, so every 2 hours we are walking into their room, we are assessing if they need to go use the bathroom, and then we offer toilet to avoid any accidents and to avoid incontinence. So as they age, they have a weakened urinary sphincter and shortened urethra in women. Okay, so shortened urethra in women, they are susceptible to what then? UTI. Okay, so from the nursing standpoint, patient education, what are we going to tell our patients? Like for any patient, especially females, wiping from front to back, okay? And then for our elderly patients, a proper peri-care. A proper peri-care. My Sienna group, how many UTIs we had? A lot. And it all boils down to poor peri-care. Like, you know, somebody's just sitting there incontinent and nobody is doing a proper peri-care. And we had a patient came in with just a hard calf, and 2 weeks later now she has UTI. And it's she's incontinent, and then we're not doing proper peri-care is not being implemented. So when we're talking about peri-care, can we use chlorhexidine or any type of disinfectant? Can we use chlorhexidine for peri-care?
No.
No, why not? It's going to keep bacteria off for 24 hours. Why not? It will irritate the skin, the mucosal membranes. So how are we going to do the peri-care then? Soap and water. So the standard of care, any hospital across the nation, standard of care is twice a day, peri-care twice a day with soap and water. Okay? Just the wiping doesn't cut it. So as the nurses, as RNs, it is still your scope, but this is something that is being delegated to the CNAs. Just because your CNAs are taking care of peri-care, you're not doing it, but we are still going to hold you accountable because it's a skill that was delegated and it is your job to supervise it. Make sense? So when you're working with your patients, there are skills that are being delegated to CNAs. As in charge of this patient's care, you are going to make sure those cares are being done. As little as peri-care, oral care, IS, whatnot. So to prevent UTIs, patient education, front to back, peri-care with soap and water. Okay, and then with age, your patient has a tendency to retain urine. Okay, so we are looking for some of the signs and symptoms of urinary retention. What are the signs and signs and symptoms of retention?
Distended bladder.
Okay. Is it something that you're just going to look at your patient and tell? No.
Oh no, you can
You
palpate
palpate it?
and then you can do a bladder scan
They have
and then check how much they voided last time.
Okay.
Or ask when they voided, how often, and then that'll indicate you need to do a bladder scan.
How about if your patient is complaining of lower abdominal pain, pressure on their pelvic floor? Does that count? Okay. So if your patient is complaining of lower abdominal pain and pressure to their pelvic area, we are going to do further investigation. When was the last time your patient voided? Okay. So the rule of thumb is for elderly, again, you're offering them, Deccan, urinal, or taking them to the toilet every couple hours, like at least 4 to 6 hours. If your patient has been voided in 4 to 6 hours and they have a good oral intake, they're like being hydrated adequately and they're not voiding, that is an indicator your patient is retaining urine, okay? With those dementia delirium patients, if they are getting agitated every few hours, it means they have to go use the bathroom, okay? Sometimes your patients, you just took them to the bathroom and then 60 minutes later, or even like 30 minutes later, they have to go again. Okay, there's a frequency and there's urgency. And then they have to go. And these are the patients that are like at risk for falls, because when that urgency and frequency hits, they're not going to stop for nobody, okay? So in this case, if there's a frequency and urgency, you're going to suspect urinary retention. They're not able to empty their bladder all the way. So they go, you take them to the bathroom, they're going to void small amount, and they will feel like maybe they're done or they're not done, but they're not going to empty further. You bring them back and later they have to go again. So in these cases, what are you going to do? Do a bladder scan. With a bladder scan, that is the most definitive, if you have a good grade bladder scanner, is the most definitive study to measure the volume your patient is retaining, okay? Every facility is different and every literature will give you a different number. So the hospital I come from is the 300 was the number. If you read 300 on the bladder scanner, that calls for straight cath. Okay, so you're going to straight cath your patient, okay? Drain the bladder, watch for them to void again without any catheter in place. And after they void, you're going to scan them again. So what is the term for that? After, like when your patient has voided, PVR, post-void residual. We are going to measure those post-void residual for patients who are susceptible for retaining urine, okay? If you have to straight cath your patient twice in a row, okay? The third time, it's a call for indwelling catheter. So now you're going to call your physician, you're going to let them know, hey, my patient is retaining urine. First time, I recorded 350, drained about 400 with straight cath. Same for the second. They're retaining again. So they're going to go for the indwelling catheter, okay? So your patient, again, when we're talking about retention, any patients after surgery, this is age, but then I'm going to throw out scenarios right here. So any patients with any type of bladder surgery or kidney surgery, okay, if you're doing PVRs, we want to make sure your patient is like emptying out their bladder all the way, okay? Patients who had indwelling catheter in place for a long period of time, let's say maybe a week or so, okay? Or maybe after surgery, when we pull that catheter out, okay, what are we watching for? Urinary retention. We want to make sure your patient is going to void few hours after we took that catheter out. Okay, if your patient is not voiding, it means they're retaining. So we call it what? It can turn into a neurogenic bladder. So with a neurogenic bladder, it's like, you know, when you place the catheter in your patient, your brain is like, you know, this is the one pathway I can shut down because there's nothing to report. That bladder is just getting empty on its own, okay? So when we pull that catheter out, we want to make sure the brain, the neural pathway is open, your brain and bladder, they're communicating, okay? So your patient has the urge to void it. If your patient will not report that they have to go, but when you bladder scan them, they're retaining, it means, you know, we need to put them on a toileting schedule. So the same as kind of like a potty training, you know, all bladder training, or like, you know, you have bladder training them all over again. Because we're trying to build that, those neural pathways. Are we clear on urinary retention?
Mm-hmm. We do the bladder training before the removal, right?
And let's say if it's like a long term, again, like we clamp it and remove it, but like in acute care settings, we remove it. Okay, like post surgical patients, or like, you know, if somebody's going home next day.
So the training for that is just take them to the bathroom?
Yeah. Just take them to the bathroom, like every couple hours, just take them to
And
the
turn
bathroom.
on the sink water.
Well,
Your
like,
water, they're gonna pee.
like it doesn't work, like every patient is different, you know, every patient is different, so
Well,
that
they
trick
pee and they go
doesn't work
home.
for everybody. Okay, then we're going to look for medication like provide privacy, okay? Not everybody's able to pee when somebody's standing and watching them.
Shy daughter syndrome. That's the thing.
So provide privacy, okay? Again, we cannot leave our patients in the bathroom alone, but then maybe pull the curtain or just kind of like, you know, leave that door like crack open and then stand outside. Provide privacy. Second, then we have meds. Make sure like the meds, any medication your patient is taking that can cause urinary retention, such as those anticholinergic medications. So atropine is one of them. Then we have our like Robinol. And there's another one like the patch. Hospice nurses, like, you know, the spokes.
Yeah, scopolamine.
Say the word, sorry. That, the patch. Scopolamine patch. Okay, so these are the medications, like some of the main medications you will see in the geriatric settings. Okay, these are the anticholinergic medications. What they do, they kind of like, you know, dry up extra secretions. Okay, and then they can also cause urinary retention. Robinol. My clicker is broken again. Okay, so the next one is your assessment. So we are going to start with just a history collection first, and then we will move into the physical assessment. When we're talking about the history collection, that is your subjective information. So we're going to check their demographic information, their age, gender, race, any non-modifiable risk factors that could contribute towards any renal impairment, and one of them is their any genetic predisposition. Then their socioeconomic status, which is their level of education, their health beliefs, access to healthcare resources. Nutritional history, so this is where you're going to ask them their hydration status, their caffeine intake, okay? Also like their diet, okay, what kind of diet your patient is on. If your patient has a family history of renal stone or kidney stones, and then they are on high protein diet, okay, and with a poor hydration, most likely that your patient is going to have kidney stones, okay, renal calculi. Any medication histories, for example, like if your patient is diabetic, do they have hypertension, okay? So with diabetes, like why it is, why we take in consideration, like when we are doing renal assessment, if your patient is diabetic. Huh? For renal failure, because with the high blood sugar, your blood is kind of like viscous, and then think about those teeny tiny capillaries, you know, blood vessels in your kidneys. That can, they're going to get damaged. Same with hypertension, we're concerned about the perfusion. So again, we were talking about like with the cardiac, anytime there's a cardiac complication, we're thinking about renal damage, how it's going to damage our kidneys. Any antibiotics, for example, like gentamicin, the vancomycin is one of the nephrotoxic medications. Your NSAIDs, any over-the-counter medications. Any family history and genetic risk. Okay, nephritis is one of the complications that is connected to as a genetic risk. And any health problems, for example, if they have difficulty initiating urine, any retention, if your patient is complaining of like burning, itching, pain while urinating, dribbling, or any flank pain. Okay, so where do we assess for the flank pain? Where are the flanks? So what is the medical terminology, like the your CVA, the costovertebral area?
Oh,
Oh Lord, that's advanced for me. Just like say right here.
Yeah, but like for our NCLEX, we need to learn, for the nursing, we need to learn all the advanced terms.
So, well, hold on, say it again. What did you say?
CVA,
Oh,
angle.
so when we're doing flank pain, CVA is like not a cardiovascular accident, it is a costovertebral angle, costovertebral angle. Okay, we are done collecting history, we are moving into the physical assessment now, okay? Have you guys done your renal assessment in the physical assessment class? Okay, so physical assessment, what is the general appearance? So when we are doing, no, you guys haven't done the renal? So general appearance, okay? Again, inspection, you're going to look at the skin, okay, and then kidneys and ureters, like, again, you will assess for the kidneys. So Professor Evans, she will tell you guys, like, you put your head and then, kind of punch your patient in the back. If there is any tenderness, okay, it means they have like maybe inflamed kidneys or some sort of like a kidney disorder going on. Ureters and urethra, bladder. For the psychosocial, now think about incontinence related issues. If your patient has incontinence, that's stress incontinence, like, our females after childbearing. We do experience like stress incontinence. Every time you laugh at a joke so hard, sneeze or cough, what happens? You pee your pants. You pee your pants. Same with our patients with like, stress incontinence, like, from like any muscular dystrophy or any muscular disorders. Or let's say, so with incontinence, like, do we like your patient is like very conscious and they're aware, like, they're like maybe like they have like a body odor, and maybe somebody noticed. So again, if they have incontinence in general, they wear briefs. So think about like they cannot wear like all type of like dresses or anything. Urostomies, if your patient has a suprapubic, like a stoma, and then they have a urostomy in place. So they're walking around with like a bag on their belly. So there is a risk for leakage and smell. Okay. Those indwelling Foley catheters. So if your patient has a urostomy or indwelling Foley catheter, as nurses, like, we will kind of educate them on like, how to use those leg bags. So that bag can remain discreet, and then how to manage and how to take care of that, like how to prevent leakages. Diagnostics. So in your textbook, page 13, 1314, it does talk about all of these factors.
1,000.
Again, for your exam, for NCLEX and MedSurg 2, please get familiar with these terms, and I will kind of like briefly touch on them. But for your test, you need to remember your creatinine and BUN. These are the two labs that are directly related to your renal function. Anytime we are measuring creatinine and BUN, we are looking at your renal function. Okay? So with the creatinine, if your creatinine is high, it indicates any kidney injury. If it is low, it could be related to the muscle loss. With the BUN, it is increased if we have any type of like liver or kidney disorder, and it is down, your BUN is down if your patient has malnutrition or fluid volume excess. So think about overhydration causing, diluting, your numbers. Then we have bun creatinine ratio, so the normal is 15:5. You don't have to remember it, but just know it. So if that ratio goes up, it indicates fluid volume deficit and high protein diet. And if this number goes down, if this bun creatinine ratio goes down, it indicates fluid volume excess, okay? But anytime we have a creatinine, if your patient is going for any procedure that requires contrast or anything, any medication that is going to get metabolized through your kidneys, we look at creatinine. If this number is high, we are not going to proceed with this procedure, okay? Because anytime we have a procedure, any invasive procedure, contrast or anything, we want these kidneys to function. If the ratio is high, it indicates fluid volume deficit. But no, I'm just talking about the creatinine. If your creatinine is high, that indicates renal injury.
No, for the diet.
For the diet? Oh, contrast?
Yeah.
It's just your creatinine. You look at bun and creatinine. If they're elevated, that indicates renal injury. Okay. For your patients, like your dialysis patients, you will find these numbers like elevated. That's their baseline. That is their baseline because their kidneys are not functioning. So it is like, elevation in bun and creatinine is like normal finding in dialysis patients. Okay. Your dialysis patients, they are not going to make urine. That is also a normal finding. So if you're a nurse taking care of a dialysis patient, and you look at their lab, their creatinine is up and their bun is up and they're like not making any urine, please do not get alarmed. Okay? Because we are filtering their blood out of their body. Okay? Then we have urine tests, we have urine analysis. So when we do the urine analysis, we are looking at the color, odor, if it is cloudy, clear, what's going on there, specific gravity, pH, if it's like alkalotic or acidotic, glucose, and any ketone. If when your patient has a high glucose, we will see the number of ketones will go up in their UA, okay? We call it like ketone spillage, like the ketone is spilling into their urine. Then we have like protein. If there's like high protein, high albumin in patients' in urine, so there's a term in your textbook called proteinuria. Then we have leukoesterates, nitrates. So when these numbers go up, okay, along with the white count going up, that is directly correlating to the UTI. Okay, so let's say your patient was complaining of back pain, they're complaining of burning and itchiness. We send a sample, urine sample. Now you have results. Your UA is back. You call the physician, hey, I have the UA results, white count is up. The next thing they want to know is what about the nitrates, negative or positive? If the nitrates are positive, that's like an indication along with high white count, your patient has UTI, okay? Then we have cell, cast, crystals, and any bacteria. So again, from the urine analysis, we can do, if it comes back for UTI, we will do the culture and sensitivity for that sample, and then it will tell us exactly which bacteria or virus or whatever is responsible for this UTI, for this infection. So urine for culture and sensitivity, again, we want to make sure which pathogen is responsible for the infection and which antibiotic they are going to be sensitive to, so we can use that medication, that antibiotic to treat this infection. Then we have composite urine collections. So there are in your textbook, there are there's a chart, actually like a table. It's like a void urine. This is the first urine in the morning. So sometimes we ask our patients to collect that first urine in the morning because it is very, very concentrated. Okay, very, very concentrated. Clean catch, we are all familiar with clean catch. What is the process of clean catch?
The void and the
So you avoid, like, we do like pericare, we advise if your patient is going to do it by themselves, we tell them to kind of like wipe themselves clean with those wipes we provide. Void, stop, and then catch like that midstream. Okay, so we are looking for that midstream sample. And then we have the catheterization. We collect samples through Foley catheters. Again, if your patient has a Foley catheter, are you going to collect sample from the back?
No.
Why not? It's closed system.
It's been sitting there though.
Huh?
It's been sitting there.
It's been sitting there. And then, that spout, like we open it, even though we clean it with alcohol wipe, but then, it's not sterile. So where do we collect samples from the indwelling Foley catheter? From the port. How do we collect it?
We clamp.
We clamp for how long?
We clamp.
30 minutes.
About like 15 to 30 minutes, just based on like, what is your patient's output like,
We clamp past
the hub. Okay. So we will clamp it for like 15 to 30 minutes, and then it depends on which product or manufacturer your facility is using, because where I used to work, it was just a lure lock. You take your syringe, and it's a lure lock, you attach it to the hub, and then you pull your sample, but make sure you clean that hub with alcohol wipe. That scrub the hub real good. Don't collect the samples without scrubbing the hub, okay? In some areas, it's not door lock, it's just kind of like a little spongy, and then you have to attach a needle. Okay, in that case, make sure you're not going to poke yourself after you collect the sample. Yes.
Yeah.
Okay, then we have our creatinine clearance, best indication of overall kidney function, okay? Then urine electrolytes and urine osmolarity. Just get familiar with these last two. Diagnostics, urine electrolytes and osmolarity. Then we have our diagnostics. Okay, we have our KUB. What is KUB?
Kidney, urethra, bladder.
Wow.
How are we, what kind of image? It's kidney, urethra, bladder, but we are doing the x-rays. It's just an x-ray study of kidney,
Oh.
urethra, and bladder. Okay, we're visualizing kidney, ureters, and bladder. Then we have our CT, with or without contrast. Okay, if we're going to do it with contrast, what are we checking? Patient's creatinine, patient's BUN, because those are the two things that like directly correlate with your renal function. And if your patient is on metformin, this is like maybe week 6, I'm repeating myself every time we talk about CTs with contrast. If your patient is on metformin, we're going to hold it 24 hours prior to the procedure and 48 hours after the procedure, and then what we're going to do, encourage hydration. So again, guys, like go back to your CT lecture from last week, and pre and post cares are the same. It's just a different organ you're looking at. All right. Sometimes we do CT with pyelogram, P-A-L-E-G-R-A-M. Right. So this is a contrast. We inject the contrast, and it is to assess for any kidney stones and obstructions. Okay, so if your patient is going for this paleo we are assessing for those kidney stones. What are some of the patient education? So let's say it's with a contrast. So we're going to look for what?
Allergy.
Huh?
Allergy.
We're going to look at their creatinine, BUN, allergies.
What was your question?
Your patient is going for a paleo
Uh-huh.
for kidney stones, like we are going to evaluate them for kidney stones. Some of the patient education.
So we're gonna educate them on the
Pre-procedure.
labs they're gonna have done?
This is not lab. So,
What do you think?
but like the patient education or some of the nursing indicators. Last, we are going to look at their labs. Okay, for the patient education, okay, we are going to encourage them to stay hydrated and then metformin, okay?
Oh.
Also, again, we're going to assess them for any allergies, if they're, allergic to iodine or shellfish. Okay? Then we have our MRI, so again, go back to your last week's lecture, we did talk about MRIs. Okay, it's just the different organ we are going to assess here. Then we have our ultrasound, renal scan. With the renal scan, we are examining the perfusion, function, and structure of the kidneys. Okay. And we do give radioisotopes. They get absorbed by the kidneys and the ureters. So when we do the scan, you can actually look at the kidneys and the ureters. And then we have renal arteriography. Again, arteriography, it is the visualization of the arteries, renal arteries. Okay. We have our cystoscopy and cystourethropy. Okay. So with this one, we examine the bladder. It is also used to remove any tumors. So, but this procedure is done under general anesthesia. It's kind of like it's a surgical procedure, okay? And we will keep our patient NPO before procedure. We will do the bowel prep before the procedure. And after the procedure, infection, pain, bleeding, these are all the risk factors that we're going to watch for. Then we have our cystography and cystourethropy. Okay, this is to assess the function of your bladder and the urethra. It's going to check for any tumors, rupture, perforation, and any abnormal backflow of the urine. Then we have our retrograde procedures. That is kind of like the backward study. It is for we will do the pelvis palleogram, and also we will include the cystogram. Then urodynamic studies, test of bladder capacity, pressure and tone. We will assess for urethral pressure and urine flow. Kidney biopsy. This is a surgical procedure, okay? We are going to do that percutaneously. What does the term percutaneously mean when we say percutaneous? Through the skin and through the tissue. So there will be an incision, okay? We will also use CT and ultrasound with this procedure. Your patient is NPO 4 to 6 hours prior to the procedure. We're going to check for their PTT, any bleeding disorders, like how thick or thin their blood is. If your patient is at risk for bleeding, we are not going to proceed with this procedure because your patient can bleed out during this procedure, or we will not be able to manage it. Also, the hypertension is managed aggressively before this procedure. If your patient is anemic, we are going to do a blood transfusion to correct their HNH before proceeding with this procedure, because this is a high-risk procedure and then your patient can bleed out. If they already have a low HNH and we proceed with this procedure, what's going to happen? Blood loss, poor perfusion, anoxic brain injury. Okay, so the post-procedure, and a lawsuit. Thank you. That's why you make friends with hospital lawyers. Okay. So the post-procedure managed for bleeding. Again, it's a surgical procedure. We are looking for, assessing for what? Infection, managing infection. Your patient is not getting septic. That site is not getting infected. Dressing site, so we want to make sure the dressing is clean, dry, intact, and it's clean. pain, and we're also managing pain. Okay, question. Which client does the nurse identify as most likely to experience renal compromise assessed by decreased urine production? Okay,
Am I?
what is, it is D, yes. How many of you guys, like, it's just, I only heard one person. How many will say D? Let's go, who? Anybody voting for A? Raise your hand. B, C, D. Come on guys, show me your hands.
D.
Josh,
I
okay,
see E.
okay, D. Yeah, it is D. It is D. Why it's D?
Okay.
So the blood pressure is low, your patient is hypotensive, and the ability of the kidney to self-regulate renal blood pressure and renal blood flow keeps your GFR, the glomerular filtration rate constant. A blood pressure that is low, 92/48, is a mean arterial pressure of 62. It's like still above 60, but it's like very low end of 60, like of the normal. So the kidneys has difficulty time regulating their GFR, which with a mean arterial pressure that is below 65. So again, circulation. A client with kidney failure whose pulse oximeter reading is 96% reports dyspnea. The nurse assesses the client that the client is visibly distressed with the respiration rate of 32 breaths per minute. What is the appropriate nursing intervention? C. Don't let the 96 throw you off. If your patients have like 32 breaths per minute, they are like not perfusing. So we're going to do, we're going to give them oxygen, and then after the oxygen, we can call the physician. Okay, then we will first we will stabilize, and then we will notify.
What was the other C?
C. A client with a history of kidney disease is admitted with acute shoulder pain. In which order will the nurse discuss with the prescribing healthcare provider? So your patient has pain, they have compromised renal function, kidney disease. So for pain, first let's say, do we give digoxin for pain?
No.
No. Do we give metoprolol for pain? No. So if you look at it, digoxin and metoprolol, they actually support your renal function by keeping your cardiac function in check, alright? So pan cultures for a temperature of 38.5, is it abnormal? Does it even correlate? No. Ibuprofen, that's the only one. We're taking care of pain, and then we know it's a nephrotoxic, and it's for 8 milligrams every 4 hours. So how many milligrams, like in 24 hours?
4,800.
Okay, that is like more than what is the standard. Okay, so just kind of looking at it, it's a high dose of ibuprofen, okay, and your patient's kidney function is already compromised, so it can cause like further nephrotoxicity and further renal damage. Everything else was just a distractor. Okay, we will have one more PowerPoint, and then I'll give you guys the key concepts, because this PowerPoint is going to tie in our GI and GU, just the elimination. Okay, so just kind of looking at it, it's a high dose of ibuprofen, okay, and your patient's kidney function is already compromised, so it can cause like further nephrotoxicity and further renal damage. Everything else was just a distractor. Okay, we will have one more PowerPoint, and then I'll give you guys the key concepts, because this PowerPoint is going to tie in our GI and GU, just the elimination. from your green textbook.
Professor, to answer the question, how come you don't want to elevate your head first?
So again, like, we will, all options are right, but what is the priority? Like, you stabilize, give them oxygen, after that you can elevate, call the RT, call the physician, but first we stabilize. So anytime all 4 choices are right, look at what are you doing.
I thought that it would be the lesser invasive.
Okay, let's take a break, 5-minute break.
It's part of,
Not for that.
it's part of, it's part of confusing.
It's part of the
Quick question.
Most
of the time.
Depends who wrote it.
But I think it's because it's
Thanks there.
My arm got all that I lost weight. So like when we go over it, I get really cold in some places. And then you have to like stop and take it back. Yeah, and yeah, my arm like really like swollen as hell. Cause like all the they make it a hole. And like this is like, yeah, we come back, bro. Cause we like, I was like, that's how it's been seen. Like my chest, it's like my chest. When I do my,
So take,
it did in some places like white.
like I don't like white.
Lines
So I think Tylenol with
it's a lighter shade.
that's pretty much acceptable.
And in my
But
chest,
it helps me
like
better
right
than
here. Oh no, this is just a thing. I'm getting that funk right there, and I'm not. Like that funk. So you know that?
Autistic parenting too.
Yeah, with like the skull shape on it. Yeah. Some people are my chest tattoo. Yeah, I'm not looking forward to it. Well, I'm sweating. It's like right down in the thyroid.
I really want to get my like
Yeah, you like on like an idea or whatever. You guys like just like I think it's like Nightmare or something like that. Like it's like a cream. I don't know what I've done, and like it makes the skin go away. Like I saw it. Oh yeah. Man, I keep running until I see them. Normally, I just either I don't like make sure before I start some motion. That's when it's done. Because like when it's time together, it comes out more. You know, sometimes I'm playing on its own. I'm like, alright, you won't do it on your own. Yeah, I'm getting like, I'm getting like all of my shit done. It's like, bro, it's actually lit, but I was like,
Video we will discuss the effects of aging on the gastrointestinal, genital urinary, and reproductive systems. Let's first look at the gastrointestinal system and begin with the teeth.
this was planned.
I don't know if you have ever looked into the mouth of another and noticed that they may be wearing dentures or missing teeth. Many different things happen to our teeth as we age. Tooth enamel, which is what coats our teeth, becomes harder and brittler with age. The dentin layer, which is below the enamel, becomes more fibrous and is not as prevalent as it would be in a younger person. The teeth may also become less sensitive. The gingiva or gums surrounding the teeth may also retract, exposing more of the tooth and the nerves of the teeth. All of these things together may lead to higher propensity for the development of cavities as well as tooth decay. The bones that support the teeth also become thinner and less able to support them. It's not normal for an older adult to lose teeth, but those who receive poor dental care are more likely to develop periodontal disease, which may lead to the loss of teeth. As we age, our tongue tends to atrophy or get smaller. This in turn affects our ability to taste. The sweet sensation that is located on the tip of the tongue is most affected. This picture shows where our taste buds are that sense the sweets are located. The sensation of sour, salt, and bitter located on the back of the tongue decrease somewhat, but not as much as the sweet sensation. This loss of taste in many cases leads to excessive seasoning of food by older adults, and in some cases the loss of desire to eat because all of the food tastes similar. As we age, our mouths also lose their ability to produce saliva. It is estimated that older adults only produce approximately 1/3 the amount of saliva as would a younger person. Not only is there a decrease in the amount of saliva, but it also becomes thicker or more viscous. There are also many medications that may be taken by older adults that decrease the production of saliva. All of this in turn may lead to dry mouths. With the decrease in saliva also comes a decreased ability to break down starches while eating. In addition to these problems, the muscles of the jaw and tongue tend to become weaker, making it difficult to chew and swallow some foods. The purpose of our esophagus is to propel food from our mouth to our stomach. This is done by what are termed propulsion waves, which push food downward toward the stomach. As we age, the esophagus tends to dilate slightly, and we use strength in the propulsion waves. This causes food to remain in the esophagus longer than it has in the past. In many cases, this leads to a feeling of being unable to swallow and can actually be quite uncomfortable. The lower esophageal sphincter may also lose some of its tone. This sphincter is used to prevent the backflow of food from the stomach back into the esophagus. All of these issues, in conjunction with a decrease in gag reflexes, places the older adult at a higher risk for aspiration, as well as the development of gastroesophageal reflux disease, also known as GERD. As the stomach ache,
Please, no GERD. Pay attention. What is GERD? So let's say your patient has a new diagnosis of GERD, okay? So, what education you will provide for the diet? Huh?
Do not lie down right after you eat.
Do not lie down right after eat.
Avoid coffee.
Avoid caffeine. What else? How about chocolate? Like avoid chocolate. Avoid coffee. Avoid spicy food. Okay.
Don't lay down after eating.
Somebody said it.
Sit up 30 minutes after eating.
Somebody already said it.
Dang.
Okay, what else?
Medications are taken before meals.
Which medication? Like, there's like one over the counter. Omeprazole, like Prilosec, or Lansoprazole, or like different name. It's just that Zole. It's the Lansoprazole, Omeprazole, and like another name is Prilosec. Okay. So the patient is going to take this medication
30 minutes before meals.
30 minutes before breakfast, 30 minutes before meal, okay? And then another patient education is like, the course is 21 days, like, they take for 21 days and then they pause. And then they restart. Why? Because it can cause osteoporosis. The long-term use of propentazole chronic pain. So mostly hospitalized people, like patients with opioids or sedatives. It is unrecognized, unattended, or neglected constipation. It will eventually lead to fecal infection. So if your patient, Sienna Group, I think it was Thursday, like when I was there Thursday, a patient didn't have a bowel movement for 4 days, 5 days. Whose patient was it?
Yeah, Thursday, I was there, I didn't see you.
It was like one of the Thursdays.
Oh.
Friday, sorry, it was a Friday. So whose patient was it? Flower's patient. So the patient came to Sienna and then, or maybe it was there, this person hasn't had bowel movement in 4 days and nobody seemed concerned. Nobody seemed concerned. So again, like with the elderly patient, if you're working long-term care, day 2 or day 3, we are kind of pumping their system with what? Like Senna, stool softeners, that go, smooth move tea, which is a Senna tea, So we're putting interventions in place for them to have a bowel movement. Because if it will go unattended, it will turn into fecal infection. And next thing you know, you will be putting an NG tube to decompress and suction out that fecal matter. Sometimes the fecal infection, if it gets severe, there will be surgical removal. I think, did we talk about the vacuum in this class?
I never know, tell me about it.
So fecal infection in some cases, there's a vacuum removal of the fecal matter. Okay?
Some weight.
It is non-invasive, it's the least non-invasive. Okay, but in the severe cases, if your patient is not able to poop even after we did the enemas or the stool softeners, whatnot. So make sure, in that case, that the fecal matter should be hard so we can suction it up. Okay?
So then you dry them out at that point, or what do we do?
So again, we clean them out and then we put them on a really good bowel medication regimen and a high fiber, high fluid diet. But if it occurs again, then it can call for a surgical removal. I've taken care of a patient, we surgically removed his poop.
So,
Oh, nice.
Yeah. So
how does
again,
that work?
in
You put them under completely, like a whole,
it's just a GI. You have some surgery, a colon
I'm gonna
surgery.
need you to that.
Huh?
I'm gonna need you to that.
But first, maybe you want to look for this vacuum suction.
Ooh, Jesus.
Alright, so removal of the fecal infection is at times worse than the misery of the condition. So when we're thinking about fecal infection and removing it, so from the nursing standpoint, it's the digital removal. How many of you guys did the digital removal of the infection?
Like done to us?
For your patient.
Oh yeah.
So it is pretty painful for your patient. Okay? For assessment, it is important to obtain a bowel history. Guys, include usual patterns, frequency, size, consistency, any changes, and occurrence of straining and hard stool. So again, their bowel pattern, how many times do they empty their bowels? Okay, the size, medium, small, large, consistency, hard, soft, any changes to their normal patterns, okay? And if they are straining to empty out any hard stools. Okay, these are the components that we are assessing. Any factors that can cause constipation must be included in the evaluation. Okay, so again, any risk factors you evaluated or you assessed could be leading to constipation or are causing constipation. So when you do your evaluation for your plan of care, you want to make sure you are looking at them and then eliminating those risk factors. So this Bristol Stool Form Scale, so this is the one we will use for those C. diff patients. Anytime you have a patient with C. diff, and then we are thinking about getting them off of precautions, C. diff precaution, okay? If you will pull your policy out for your facility or for your hospital, you will see this part of, there's like a nice picture of this Bristol Stool Scale. It will tell you different kind of tools, okay, at which consistency we can take this patient off of the C. diff precautions. I think it has to be like 2 or 3 formed stools, like, in a 24-hour or like in a 48-hour window. Again, like, read your facility's policy, but when you're taking care of a C. diff patient, this will come handy. Then we have interventions, non-pharmacological interventions. Physical activity, so the non-pharmacological interventions are what? Like Senna T, physical activity, positioning. So again, if your patient is like incontinent, like bowel incontinence, okay, you give them bedpan, or like well, they can't go to the toilet, you give them bedpan. Will you just keep them flat?
No.
That's not
Gonna
the proper
bend them a
position.
little.
You're going to sit them up. After you put the bedpan under them, you're going to sit them up in an upright position, so that the DMT can help push this bowel out. Toileting regimens. If they have a toileting schedule, please stick to it. Pharmacological interventions are your suppositories, enemas, what else? Yes, suppositories and enemas, or like stool softeners, leg sticks. Fecal incontinence is the involuntary loss of liquid or solid stool that is social and hygienic problem. And fecal incontinence is also related to UI, your urinary incontinence, and then also UTI. Okay. Which is a risk factor for urinary incontinence?
I'm just gonna start choosing smoking for everything.
Pretty much.
All of the.
Pretty much. Okay, what is
All of the above.
all of the above? Which person have the highest risk for fecal incontinence?
You know, people living in this.
Or nursing homes.
Oh, no, one time I stuck this repository and I put my finger out, like it just all came shooting out of it. 6:15, that'll be all shit. Covered.
So this is the person residing in nursing homes. Their highest risk for fecal incontinence, just like their age.
Oh, no.
So
do we not need to know?
Yes, and a boy.
Types of laxatives for the test?
Yeah, right here.
Maybe the person you have is going to help you. It was part of your final.
No, that's what I meant.
Yeah. So, next week I will be here, because like my mental health orientation is moved to Tuesday, before it was going to be Dean Vista doing next Monday's lecture. Which was, I was like not very happy about it, because we want to do our comprehensive review. Hey guys, I want everybody to pass.
Is our exam on Monday or Wednesday?
For the final,
No, the next exam.
it's a Monday.
On the schedule, it has it on Wednesday.
I apologize, when I was maybe scheduling it, I must have made a boo-boo. I'll change it.
Wait, so what's happening on Monday? What's not happening on Monday?
So exam 5 is on Monday, just ours, the regular 8 to 9. So I think like when I was putting like dates and times there, I must have like, made a mistake. So I'll change it. Okay, so let's look at the key concepts for your GIGU. So know about your NG tubes. the purpose, the procedure, and the patient care. So if there's any obstruction, impaction, or in case of like, your patient has ingested anything poisonous, we will do, and we do the NG tube, it is for the decompression purposes. If they have any, issues that they cannot have a PO intake, and then we want them to have nutrition, then it can, be for the feeding purposes. Okay. Know about your GERD. What is GERD? Just the basics, guys, like, what is GERD? You don't have to go like all the way down, deep down into this disease process. Just like know it from the nursing standpoint, okay? Patient education, pharmacological and non-pharmacological management. Foods that your patient should eat and the foods your patient should avoid.
What food should they eat, like calcium?
Yeah, calcium-rich food, anything that is not a stimulant. Constipation, your patient teaching for constipation. So, your intermittent indwelling urinary catheters, patient care, and the management. UTIs, the risk factors, prevention, your incontinence, stress incontinence, urge incontinence, functional incontinence. Urinary retention. I think like when we were going through the labs, but like that's part of the reproductive system. Let's go take a break.
We don't need to know the background for this
There are like, I think like maybe one next year. I will let you know.
These are all the ones with the red surge.
Oh, what's going on? How are you? Sorry.
I do.
Yeah.
No, last night I ate so much food and it's like I think all the acid got really So I slept for like 2 hours and I woke up at 12. And I've been up since. So that's why.
Oh, that was so nice. So nice. Oh my God. I knew there was some behind that. I knew it.
Sorry, bro. We've been talking to Chandra for the last meeting
So, there was a student survey that came from like student services like a few weeks ago. I was reminded to remind you guys to complete it. It's like for a unit check, it was a student survey. It should be in the email. Huh?
It sounded like it.
Did somebody like, somebody from HR or from the administration approached me like Friday, please remind your students of
Yeah,
to
so-
complete that survey.
All
Alright guys, let's finish this.
What do you think? I saw her go like she did.
Okay, yeah, I'll call you back.
I know where he's flying.
I bet. Okay, I'll see you. Yeah. Nah, bro, I'm too short for that. I can take a flight right now and have a party. But it's like too much. Say too much already. I can take one vitamin and buy like I'm not hungry to get out. I would I'm saying, but that's the life. Because if you die, you like all the tech in your mouth and you I'm not going out like that. No matter how I maybe I'm trying to push it on board right now. I don't know that. Maybe I'm straight to one guy. My nose is already Why are you looking like that? I'm testing one. Wait line. I'm not doing that. What about one of those? You're not the same. I remember every single thing. I'm about the traumatic stuff too. Oh no, that's traumatic. I'm on the dad was really like, this happened. Stop talking about that. Well, my dad was like, yeah, you're right. I did do that too. Our dad was like, when I made you cry, I said, man, that was the stupid thing in your body. Yeah, no, I remember it wasn't very traumatic. They should look at it differently. But like, it was for your benefit. You said, I smacked you with my read on you, and your lips were up your mouth. Mother, she said yes. You know? Then my sister so hard she flies to the refrigerator, and she's got a bloody nose. Oh, she's doing the dishes. Huh? This hurts more than hurts you because I'm breaking my hand. Exactly. Dad would come home, start screaming. Why are you screaming about? I was like, I never screamed at you.
Do you want
You're aware we're going to talk about reproductive system diseases and disorders, but before we actually jump into the male and female reproductive system with these diseases and disorders, let's do a brief overview of the male and female reproductive system. So if we look at the anatomy and physiology, especially when we're talking about the male and female reproductive systems, we're going to see some major differences. In a lot of the other body systems, male and females are very similar when it comes to the structures that are present. In the reproductive system, there are some differences. Now, ultimately, physiology-wise, we see that they do produce hormones, whether it's male or female, and they do produce gametes. Gametes are the sex cells, but the sex cells are different. Males produce sperm, females produce egg. These structures are also going to be very different for the female because not only does the female produce the egg, it also has to then allow for, when fertilization occurs, the development of the fetus and the baby. So there are going to be some different structures. So let's look at the female external structures first that are present. We see that you have the uvula. This is going to be the outer kind of opening or vault of the reproductive system. This is going to be lined by the labia majora and minora, which are known as kind of the lips that are present. We do see that the labia majora are going to have hair that's present, whereas the minora, which are the inside, are just going to be hairless. We also see that there's the clitoris in this area. The clitoris is going to be the area of arousal for females. It is going to be homologous in the sense to the tissue that's found in the penis in males. We have the vestibule and vestibular glands. This is the opening that's going towards the vagina itself. This area is going to have glands that help produce mucus, and this mucus is going to help protect the vagina from potentially foreign invaders, but it also lubricates for intercourse. And then the vaginal orifice is also here, which is the opening into the vagina. Now you will notice as well in this picture that the urethra is a complete separate hole than the vagina. The urinary system and the reproductive system are not combined in females. We do find that there is a common exit in the reproductive system and urinary system in males, but not in females. Now, if we move on into the internal structures that are found with the female, we do find that we have the ovaries. The ovaries are the organs that actually produce the egg. They also produce several hormones that get released. They are what we would consider the female gonads. The fallopian tubes are going to be the tubes that connect the egg, or kind of siphon the egg that's released by the ovary and directs it towards the uterus. So they are more of a connection. Now they're not actually connected to the ovary, they're just next to it. So the ovary is like here and the fallopian tube is here, kind of setting over it. So when the egg gets released, it kind of sucks it up like a vacuum and it sends it towards the uterus. The uterus is a pear-shaped organ that sits on top of the bladder, and this is the place where, if fertilization occurs on the egg and it implants, this is where the fetus and baby will develop. We then have the cervix, which is the neck region that is going to connect the uterus to the vagina, and the vagina then is that opening out towards the outside. The female hormones that are produced by the ovaries are going to be estrogen and progesterone. Now, if we look at the male structures, we see the male has some external structures as well. These include the scrotum. The scrotum is going to house some internal structures that we call the testes, and then the penis. And the penis is this outer structure that actually has the urethra that runs through it. This is the structure that is linked both to your urinary system and the reproductive system in males. If we move to the internal structures, we have the testes. The testes are the male gonads, and they are the ones responsible for producing sperm, as well as producing testosterone. We see that the area right above the testes is called the epididymis. The epididymis is going to be responsible for maturing the sperm. As the sperm is made, it needs to mature in order to be successful in finding the egg. So this area is where it gets matured. And this is also an area that does some quality control. It checks the sperm out to make sure that it's good quality before it hopefully enters into the actual semen. Now, this is going to check for things like if the head's not made correctly on the sperm, if it has multiple tails, things like that. The vas deferens, guys, is a series of tubes that connects the epididymis to the ejaculatory kind of duct. These are going to be a series of tubes that transport the matured sperm. There's also some seminal vesicles here. Seminal vesicles are going to help produce the fluid that makes up the semen. This fluid is going to contain sugars as well as buffers, so that it can help neutralize any urine that's left behind in the urethra, but also has sugars in order to provide energy to the sperm so that they can swim and find the egg. It's kind of like packing them a lunch in a sense and getting them ready to go on that adventure to looking for the egg once they're deposited inside of the female. We also see there's some other glands that help with the production of this semen as well. There's the Bartholomew's gland and the prostate gland. So these are all going to produce different secretions that help aid the sperm in their travels as they leave the male and enter into the female.
This game, you're not ready for it.
Now let's talk real quick about some common signs and symptoms that we see with the reproductive system. So in females, some of the common signs and symptoms are going to be things like abdominal and pelvic pain, fever and malaise where they just don't feel good, abnormal vaginal discharge, burning and or itching in the genital area, pain during sexual intercourse, any change in the breast tissue could be a sign or symptom, and abnormal discharge from the nipples. So these are going to be the common signs and symptoms for the female reproductive system. On the other hand, for the males, we see that they can have urinary disorders because the urinary system is going to be linked to the reproductive system. So this includes things like frequency, dysuria where they have pain with urination, nocturia where they need to go to the bathroom during the night continuously, and even incontinence. Males can also have pain in their pelvic region as well as the growing and reproductive organs. There could be lesions on their external genitalia. swelling of the reproductive organs, abnormal penile discharge, and they can also have burning, itching of the genitals as well. So diagnostic tests are going to be a little bit different based on male and female. In female, we see that there is going to be a bimanual examination that is done a lot of times when women go into the gynecologist. We also see that they can do a hysterosalpingogram. This is going to be where they take an x-ray or a type of imaging where they're going to look at the female reproductive system. One of the most common tests that we see with females are going to be the pap smear of the cervix, where they're going to scrape some cells off the cervix in order to take a look at them. A pathologist would look at them and see if they're abnormal in any way, and this is going to help detect hopefully cancer if cervical cancer is present. We also see that they could do a cervical biopsy if they do notice that there's potentially some cells that are abnormal, and this is where they actually pinch and kind of cut off a piece of the cervix. Another one is the cone biopsy, and guys, a cone biopsy gets its name because it takes kind of like a cone-shaped piece from the cervical tissue, but it also includes some of the endocervical lining, which is inside of the uterus. So it's not just scraping the actual outside of the cervix, it's going a little deeper into the uterus. We also see there could be a dilation and curettage, and this is also known as a D&C. This occurs whenever endometrial cancer is discovered. They'll do like a type of biopsy that's deeper, and this is going to involve a kind of surgical dilation, sedative, where they're going to do some dilation of the cervix, and they're going to scrape the uterine endometrial lining. D&C is also commonly performed with the uterine bleeding following a spontaneous miscarriage or abortion. And so what they do is they have to go in and clean out all of the dead tissue when a miscarriage occurs. And when we look at this, they're going to, again, remove that lining, the endometrial lining, which is the lining inside of the uterus. We also see there can be some laparoscopy that can be done where they go in with the camera to take a little closer look. A mammography or a mammogram can be done to look at the breast tissue, and then even blood tests could also be performed. In males, they may do a digital rectal exam. They could also do a cystoscopy. A cystoscopy is where they go in with the camera through the urethra, the penis, that area to the bladder. So they can also check out parts of the reproductive system as they do that as well. Biopsies could also be done in order to check for tumors or potential cancer, and then laboratory tests can also be looked at. Now, when we look at laboratory tests for males, this includes various prostate-specific antigen tests to look for things like prostate cancer. All right, the last little thing in the...
Okay, so the pap smear for this test is for females, males? Females. So at what age we are going to, it should be started, and how frequent it should be done? Pap test? Like 33 years?
Every 3 years. 21 and 29, and who are sexually active, you should have a pap test every 3 years.
Okay. So anybody who's the age of, like females at the age of like 21 years and older? They're sexually active?
I was gonna say, yeah, isn't it since these girls
Yeah.
start sexually active, yeah, they just going down.
Okay, now the last one is your PSA for our males.
Prostate specific.
Okay, that's your prostate specific antigens. When it's elevated, what is the normal range?
Less than 2.5.
So the ATA, per ATA, it is from 0 to 4. That is the normal range. Anything above 4 indicates inflammation, prostatitis, any prostate injury, and if the PS is elevated along with the prostatic acid phosphate, PAP, that indicates prostate cancer. If your PSA and your PAP, they're both elevated simultaneously, that indicates prostate cancer. It is just not inflammation or inflammatory process or some sort of infection happening for the prostate.
When we look at laboratory tests for males, this includes various prostate-specific antigen tests to look for things like prostate cancer. All right, the last little thing in this kind of like intro or review I want to talk about has a little bit to do with women and their cycle that takes place. This does deal with hormones, and there's a lot of things and factors that go on in order for this process of creating an egg and potentially getting it ready for implantation to occur. You'll notice that the hypothalamus is going to be part of this in releasing gonadotrophic releasing hormone. This is going to cause the anterior pituitary to release follicle stimulating hormone as well as LH. You'll see that they are released at different stages and during different parts. There's an ovarian cycle that takes place in the ovaries in women throughout the month where they release the egg through ovulation halfway through. And then you also see there's a uterine or menstrual cycle that takes place, and this is inside of the uterus. So there's a lot of different factors that go into play when we talk about that monthly cycle in females, which does lead to some of the problems that we will discuss in the next lecture. All right, so this kind of just finishes up a little bit of the intro to the reproductive system. Again, if you have any questions or concerns, let me know. But we're going to follow this up with a female, mostly focusing on female reproductive disorders. And then we'll do one that finishes up the chapter looking at male, as well as some of the STDs and that sort of thing. So again, any questions, please let me know.
Okay guys, let's practice. Alright
guys, so we are going...
So let's say if you're doing, working in a clinical and then your patient is a sex worker. Alright, they have multiple sexual partners. How would you conduct this interview?
Not a judgmental factor.
Not a judgmental way, very unbiased. Okay. Some of the education, patient education that you will provide. Use protection. What else? Huh?
She needs cervical cancer.
Mm-hmm.
She's a risk for cervical cancer.
Yes, so again, like as Sarah mentioned, like, she needs to get like her routine screenings done, lab work done. So use protection, birth control is must. And then again, like, please guys remember, doesn't matter what disease process you are assessing for, anytime you are in that interview phase, remain very, very unbiased. Doesn't matter, it is reproductive assessment or cardiac assessment or neurological assessment. All right. Do we have any special screenings for female screening for at the for the age under 18?
Wait, what? Repeat that real quick.
Special screening, like labs, diagnostics that should be done routinely for females under the age of 18.
So did they get nothing done?
HPV.
So they get HPV vaccine, but do we have like routine screenings for them? No. At the age, under the age of 18, we do not have any routine screenings.
But if they confess to the doctor that they're actually...
If they're sexually active, then
they better get a pap smear.
then they can get pap smears, and then of course like STI screening. And then the same education will go in place. Alright, so let me just gonna give you key points for this chapter. There's like not a whole lot. So work on your therapeutic communication, especially when we are conducting reproductive health assessment. It comes handy. Okay. Labs or diagnostics for female, like any routine diagnostics that we can perform, like pap smear. Diagnostics for male, labs. Okay.
Listen, if I get my prostate taken out.
So, like as a nurse, when you're doing a reproductive health assessment, okay, what are some of the abnormal things that you look for, that you get concerned about? Do you get concerned about their sexual orientation?
No.
No, that should be least of your concern. Like bleeding, pain, any tumors, masses, any abnormalities, they should be your concern. Not their sexual orientation. Read up on mammograms, just kind of like patient prep, before we send a patient out for mammograms. How should we prep them, or how should they prep themselves?
No deodorant.
No deodorant. Should they be on PO?
No, doesn't matter.
Okay.
No lotion, no deodorant, and for them to get over.
So anytime your patient has an invasive procedure, it doesn't matter for GI, GU, reproductive system. Okay, what are, tell me some signs of infection, like, you know, the signs and symptoms of infection. Redness,
Swelling.
Drainage, no,
drainage,
well, like, smell, like,
temperature, fever, loss of function. Okay guys, that's it. Have you guys completed that Survey Monkey?
yeah.
Okay, if you guys have completed the Survey Monkey screening, you are free to go unless you have any questions.
This morning I saw that on
Korsky guys.
Oh, Josh left.
Oh, never mind. I'll take care of it. Don't worry. I'll take care I need to fix your pockets.
My brother in Christ, I got to my reflection. I got like this old my wrinkles.
Okay, fine, yeah. Sorry. I was waiting for you.
I don't know, I'm alright. Because Alfred was a person
I'm always nice.
So he said they're gonna reserve it to see if, and I messaged him and they said if
Yeah,
You never.
she said she'll be.
That's so rude. So rude.
I'm gonna go get my doctor.
I'm laughing.
Let's let the kids who are having other
It's my only time I'm off. One time it's out there. I never off it.
Yeah, because that's what conquered. I tried to get them to get me one, but they haven't, Alright.
But I ain't gonna lie to you. I did a Chris Cracker joke.